Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with two docs, Mitch, Augustine. How are you guys doing today? Awesome. So today we're going to be talking about mobile surgical teams, and they're operating in Asia. And Mitch, why don't you just do a quick introduction of yourself?
Yeah, I'm a U.S. doc. Family practice is my specialty, but I worked in emergency rooms for several years.
Okay, perfect. Augustine?
Yes, hi, and for the team unit, I'm with general surgery. Yeah, I served for the frontline. It's for 5 years.
Okay, awesome. Well, you guys definitely have the experience to talk about this. So, obviously the topic, mobile surgical teams, that's a big push when it comes to more modern warfare. We see it over and over in Ukraine. Most surgical teams need to bouncing around because they are actually targets. Okay, so essentially, I guess, how does this work with this organization? Do you have an entire team together, or is it a couple of well-intentioned people and like you pick up certain specialties from other places?
Yeah, we actually started a training program before the war started. So that helps in that we have a whole group of people that we've trained already. And so when it came to needing talented, skilled people, we had them available. Okay.
Does that training program like continue on, or was it just yeah?
Yeah, no, it's a 5-year PA training program. So
holy cow.
It's the focus was to be able to handle 80% of the problems that are common to the area. So malaria, the whole malaria, typhus, typhoid kind of thing, as well as asthma.
So, you're getting ready to do a trip over there for X period of time, right? You can't just bring like a surgical suite with you, right? The train's not going to allow for that. You probably don't have enough people to do that. So, like, what kind of gear do you bring? What do you bring with you? Because you can't get it in the country. What do you decide? Like, where does that decision, how do you make those decisions?
Yep. So let me step back and tell you how we started our first round. Was we as I said, we have a hospital with a training program there, and we started seeing people coming in 3 and 4 days to get to us. They would bypass local hospitals under control of the military and come to us. And some of these, we had a 14-year-old girl come from the area, traveled 4 days, and she had tourniquet on. And so she ended up losing the leg, of course. We thought how we could, the mantra in, the ER is, the golden hour after something happens, not the golden week. So we decided, hey, we can do better than this. Let's put a team up closer to the fighting. And that really came out of that, seeing that need, because a lot of the tourniquets can be adjusted, taken off sometimes, or you pack the wound, tie off stuff. So, and that's more Augustine's field. But so we moved closer and basically set up with what we had. We also have an engineering tech training program. So we brought one of our engineers along, and that's a key. It's really difficult to run a hospital without power, for example. I'm in, and a lot of these places, have that. And so we took a generator, an old diesel generator that the village had that was broken, and we fixed it and used that for our power source. And the engineer did that. Set up a tarp for a triage area. We just had bought the biggest family tent we could in a retail store, and it was about half as big as we needed. And we would eventually take two of those tents and duct tape them together and cut out the middle, and that worked pretty well, actually. But so we were using just the things that we had at hand. Old school benches. We took some, and the engineer would do some splicing to make them sturdy, but that served as a operating table. I was just thinking to say whether that was adequate or not, but so we were just really improvising. Now we carried with us, of course, an old steam autoclave and the surgical equipment that we need, and the medicines. The medicines was the big deal. You need to, in fact, our first kid that came in and stepped on the landmine, we'd have given them like 10 units of blood, which was like half of our blood bags. And so we started realizing, oh man, we need a lot more supplies, medical supplies and medicine. So we put out a word asking for that. So other groups, are there anybody in the area? So
yeah, because that's always the thing, right? The more equipment, the better logistics you have, the more people you can help.
Yeah, absolutely.
However, the more stuff you have, the less mobile you are. Your risk is even higher. So when it comes to mobility, like we're talking about building tents and benches and things like that, which is obviously great, is the intent of, if we have to move, like I'm grabbing the surgical instruments and we're moving and leaving everything behind, or do we pack all this stuff up and go somewhere? Because like a diesel generator probably isn't super easy to just find.
Right. So what we did is, in fact, we've been bombed several times, and we would just pack up stuff. It usually takes us a day to move. As soon as we find a new location, we usually send out somebody looking for another location right away. So you got the next plan, next move planned out. But then it would take us a day to set up, so that there's a gap there that is, we ran into some trouble with that. We weren't ready, that for a day, and that can lead trouble.
Yeah, because essentially a day to tear down, a day to set up. So that's 2 days down with casualties mounting, right? Is this a drill that your team, do they perform this drill? Like, okay, so these are the priority things. We're going to scoop these up quick and run. Then we'll come back and, tear down when everything is safe. Because I can't imagine, I definitely would not be super happy about having to tear down a camp while they're getting bombed.
Yeah. Sometimes we can take the essential stuff first and come back. It kind of depends on the setting. We've always been able to do that. Grab all the stuff basically, and out and move. That's the balance, right? If you, like you said, if you don't have the stuff, you can't do the work. Not really. And
so, I guess just broadly, like what procedures generally are you doing?
Go ahead, Augustine.
Yeah.
You're up.
It's good Christian, and I'm talking about so much on that. So we try to do all the life-saving measures in the frontline hospital. frontline mobile site getting. So this is the main reason why we go down to the front line, because like Pupu Mitch said, the transportation is the big problem in our country. It takes 2 or 3 days to catch them to facility hospital. So that's why we need to decide. We need to go down to the nearest place of the better zone. That's why we can save the life. So we get a lot of surgery, mainly the life-saving surgery like the chest tube drainage and education, bleeding control. So we start with this kind of surgery. Tracheostomy. So I think so. We did all the life-saving measure in the front line, non-negotiable, as much as we can. Yes. Playing it.
Okay. So you're just doing the bare minimum life-saving interventions like you mentioned, and then they're moving on to another facility or another location that you've already set up?
So there's, yeah, go. We have 2 kind of patients. One is, so the problem is, we stabilize the patient, we make a life-saving measure, and patient condition is good. But the other problem is a little bit difficult to send back to the tertiary center or something like that. We don't have enough tertiary hospital, facility hospital. So if the patient condition is good and we can keep at the frontline hospital, we keep at frontline hospital for a few days, and then if their condition is good, we send back them to the barricades, clinic, and hospital. We spread out. Right if we need advanced surgical procedure or advanced life-saving measure, we send back to our main hospital. We have this hospital, so we send back to our main hospital. And some cases, like the orthopedic cases, fractures or something, we cannot, like a head injury, we cannot do at this hospital. We send back to the other country. Yeah.
Okay. Yeah, absolutely. That makes sense.
Dennis, I had a couple comments to listen to Augustine. One of the things that we really value when we're doing our teaching with the students is to be able to improvise. And, this critical thinking is really important. We had, one of our PAs, this guy had a flail chest and it ran out of chest tubes. And so he took, a urine catheter, a large urine catheter, and turned that into a chest tube. And that's the kind of thing, we didn't teach him to do that, but he's just thinking critically. And this is one of the guys that we've trained. So that improvisation is really an important idea.
Yes, especially when you're working in the austere environment, you have limited supplies and you have a bunch of work to do. If you understand the principle of whatever that device was doing, you probably can improvise it.
Right. And the other thing I was going to comment was we use a walking blood bank. So I'm getting a bunch of blood bags, and of course, we type everybody, our whole team. We will because we're set up there for long term. We'll talk to some of the villages around and see if anybody there. Talk to them like they're a little bit resistant about don't in blood. Talk through that process, and then and sometimes what we can take lately, it's been working really good, is just getting a group of students, young people that want to help, and they're hanging around, just to be blood donors. Have them there ahead of time. That's an important concept, is trying to locate your blood supply before you need it.
Is that like the primary is a walking blood bank, or do you have a storage?
No, if Sudhi's talking about storage, then you're talking about having to separate it, and then you're talking, refrigeration and all that stuff. And it's if you got the blood available, whole warm blood, it's the clotting factors work, it's warm, platelets still work, so it's pretty good, hard to beat, really.
The key is just being able to get it.
Yeah, exactly. So if you make those arrangements ahead of time, and then the people we work with are just a wonderful group of people that are community based, and if you can explain to them how this is going to help their own people, they're very willing to pitch in.
Yeah, absolutely. Like if you can keep, in the good graces of the locals, they will help you.
That's actually one of the principles that you wouldn't even try to do it without that. That they know the land, they know the situation, and you take care of them. I mean, they are that right after that landmine kid. The next two cases were obstructed labor cases. We end up doing C-sections on, and we were their best option. These tent and duct-taped tarp. What up? You imagine being in labor for 2 days, and that's your best option. That's pretty desperate. So it's that's one of your biggest strengths, is being able to work. And so our guys all know the language. They're part of that group. So
yeah, knowing the language, being able to make friends, like that is directly tied to how long you're going to live doing this work.
I mean, to be honest, that's the really important part, I guess, is to ask yourself first, why are you doing this? And for myself, I just love the people I'm working with, and that's what's attracted me to help. That's a lovely group of people. I want, from the bottom of my heart, I want to help them, and they help me. It becomes mutual benefit. So I think that's a really important. If you're just doing this for adrenaline rush, it's not worth it.
It may be a dumb question. Why can't they go to the local hospitals? Is this a distance problem, or is this a security problem, a safety problem?
I think this both. Yeah. Well, you mean the local hospital means the hospital, right? The government.
Well, I mean, like, why? So,
Sorry.
Yeah. Why? Like, is it dangerous for these people to go to an actual community hospital?
So the first is first of all, we don't have enough and high tech surgical facility hospital. We don't have enough hospital in the Warsaw from our side, but there's a enemy side. From the enemy side, they have a hospital, but we cannot send there because they are our soldiers, our knights. So if they go to the hospital, they will be captured, and it's like a disaster. So it's not possible. Yeah.
But even the civilians don't want to go if they're injured or have problems. They are afraid it's guilty by association. And so again, we're talking, can you imagine having your teenage girl's got a, severe injury, and you choose to carry her 3 or 4 days to get help. And there's like several hundred bed hospitals near where the injury happened within 2 hours, and instead she go in 4 days. So that's the same thing with the labor cases. There are hospitals around, but they're just too afraid to go there because they'll be, you come in outside, you must be associated with the resistance.
So that makes sense, right? Now, in order to do all this work, you actually have to arrive. So how is it that you go from wherever you're living now to actually arrive at the country?
I think that's again, going back to principles, I'm not going to give details, but we are invited by the local leaders to participate in this. So we're going under their, with their permission, and and they will tell us to do stuff. Sometimes we don't want to do. It's really important, I think, that you're not just doing this on your own. That you are going, people know about you, then you can tie into their systems as well, whether that's logistics or communications, or they're going to take care of you. So that's we're tied in very closely with the local community, I would say, and I think that's important as a principle. Otherwise, you don't know, especially you don't know the language, you don't know who's who. You end up doing more damage than good, and you may get killed in the process. So, or worse, half dead. All dead's okay, but being half dead's not. Especially in those settings, you become a patient, and if you have expectations of a different standard of care, they're gonna do everything they can for you. But we don't have access to morphine. We're giving guys with amputations, tramadol and Tylenol and Tacbenic, and that's if you have to realize that that's the best we have, and that's going to apply to yourself if you're injured. So,
right. So the local communities, they're arranging travel from closest safe country into not safe country.
Yeah, certainly with their permission and their help. Yep.
Right, but it's a rat line, a pipeline essentially that they've created and move you through.
Yeah, and same with the patients out, like the orthopedic cases that we're transferring out. There's other groups that can handle that, so we're tied in with other groups that they can both finance and get those people to established hospital tertiary centers in other places.
So you finally get into your country. You've kind of set up, like, how much room roughly do you need to actually operate this hospital? How do you decide how close to the battlefield, the front lines, are you actually getting?
I think the closest we've been, a mile maybe away from. We can often hear the sounds of the battle going on.
Maybe it's about 10 minutes.
I would say
10 to 15 minutes from the.
That's the closest. Yeah, that may have been too close. It's about one. But that being some things that I think. Also, things are changing with the drones and the air stuff, where you to be hidden is really difficult, and it's just a matter of time before they can track on the ambulances bringing people to you. So having a spot where they can disappear and the ambulance can disappear, unload quickly, and then the ambulance keeps going or something. You just need to make it so that it's not obvious where you are. Having generators is a big heat signature. So the location is, I think, being dictated more by those kind of things than how close. And then you work with groups of people doing transport. And for us, there's a couple other groups that are working those, getting injured people to us. And again, we're tied into their communities. So they have abilities to, if a pregnant lady needs the help, then they can get her to us. So we're tied into the airbrain pit. But the downside is everybody soon knows where you're at. So, and that mobility then becomes then you just got to pick up and move again.
Right. Because you're not associated with the actual military or the resistance or whomever. You're not for them. You're there for the area, the community.
The people. Yeah. Anybody.
For us?
Like anybody. But it includes our so the soldiers that are, they're so it includes them too. But
So you're not following the military around or the army around. You're set up in a location like we're here to protect this region or provide medical coverage for this region, and we'll take on all comers. You're doing your work. You're, like we mentioned before, you're getting casualties. The procedures that need to happen that you can't provide, obviously they need to go. But I guess how do you really triage? Like, I can handle this, because you have to be mobile, and you're trying to do the best for as many people as you can. But at some point, you're going to have so many casualties, whether they're ambulatory or not. They're not going to be as fast as everybody else. And now you're not mobile.
Yeah. So good question. And I think the key is making arrangements beforehand, so you know what, and we're trying to move people out as fast as we can. So if it's just a non-orthopedic injury, then, we got to set up place for them maybe a couple hours away, get out quickly. And the guys with orthopedic injuries will go to a different direction. If Augustine's done a laparotomy or something, we'll keep them for a few days until they're stabilized, and then we'll send them also for recovery somewhere else. So I think making those arrangements ahead of time, that's been the best for us, is we know where people are going to go as soon as, and so we're stabilizing people, just get them out quickly.
So the equipment that you're using, like the chest tubes or the tracheostomy tubes or bandages, etc., just the stuff, are you buying that on the local economy or getting that off the local economy, or are you depending on outside?
All above.
All the above, right?
We get from anywhere we can get it.
And so that in itself can be a blessing and a curse at the same time, because the same casualties that we've saved and stabilized, if they have a chest tube that says "Made in America" in great big red, white, and blue letters, that would stand out if somebody were to find them.
Yeah, well, we're sending people to fairly safe places. The biggest threat to them is airstrikes. So
okay, well, luckily their cameras aren't that good. So okay, but I mean, is this and
it actually is to the point where, I mean, frankly, they're just bombing everything anyway, so it doesn't really matter. Made in USA wouldn't attract them any more or less than in the hospital.
So is it just that they're seeing groups of, like, are they looking for a hospital, or are they just looking for groups of people?
I think as if groups of people. It's basic tactic is to instill fear, and it seems like if people are not responding to that, they don't have anything else.
So I mean, like, they're just bombing local villages.
Mm-hmm. For no strategic value.
when it comes to groups working around, being mobile, handling patients, what advice would you give to let's say a brand new doctor who is just full of love and wants to help everybody, when he wants to join an organization or just get involved?
Yeah, that's the first step, is why you want to do it. Ask yourself why you want to do it, and it better be, got to be worth it.
Yeah, because it might take your life.
Mm-hmm. And you can't replace that passion, and the people you're working with sense that too. I mean, if you're passionately working with them, then they're going to be that. It's an awesome team that happens, and you need that strength from each other during these things, and I'm sure you know that from your own experiences. You can't be out there solo. I don't think you could and maybe help a few people, but not on scale.
What advice would you give to somebody who is just brand new to this?
Well, yeah, that like roommate first. How say?
The same?
Yeah.
Okay. I'm Dennis. We both of us are come from a faith background, and I think that motivates us a lot too. So we will pray about things, and there's been several times we've been ahead of stuff that happens, and we look back on it and says, "Man, God, we did that," and we feel that God is in the mix too, and he's helping guide us and lead us to end the steps. And as Christians, there's often, we follow a Jesus that faced a cross, so we're not going to be suffering, or that it isn't going to finish us, but that we aren't alone. And I think that's when you're sitting in a bunker and the jet's diving on you, and that becomes really important.
Sure. Speaking of bunkers, I know in Ukraine they have they've a lot of their, I wouldn't say they're very mobile teams, but they're maybe we would call it like a role 2 or role 3. Like they're doing more definitive type surgeries. Have all gone underground to help with drones and surveillance, etc. Not every country is that even possible because of terrain, because of what's in the ground, right? So has those things worked for you? Have you been able to do those things?
Not really. I think this frontline hospital is much more depending on mobility. I think the one thing that we still haven't really addressed very well is just nighttime light security stuff. It's 50 guys coming in and at night, and you're trying
Everybody's got their headlights.
Yeah, trying to triage people. It's just very easy to get way out of hand, and so I think to go underground, you really have to go pretty deep to get away from these guys. Are 500-pound bombs and stuff. It's you can't just dig a little hole and come it up and call it good. So
no, it's definitely machinery involved, and at least in Ukraine. Yeah, expensive
too. You got to have somebody supporting you big time to do that, because usually those are reinforced concrete, right?
Yeah, if they can. So it's reinforced. Yeah,
just right there, reinforced concrete is. All of a sudden, you're going to have concrete, rebar, sand, gravel. That's a huge, and then do it in a secret way. I think it's becoming this. I mean, with the amount of surveillance going on. It just, I mean, those guys are the masters, so I guess they know what they're doing. But for us, it really difficult. It's that much more difficult to do. So we haven't really gone that direction to try to protect people with trenches the best we can. And
because I mean, like you're looking at a lot of the islands in Asia, a couple of feet down and you're hitting a rock or a coral or something like that. So, you can't just dig everywhere in the world.
Yeah. Or rains, half the year you have rains that are
like a pond
pouring in.
For our room, we become a pond, swimming pool.
Well, awesome. Is there anything else that you'd like to educate us about when it comes to mobility and surgery?
Levelity of the thing, because we have a good lexan with it. Professor Abermy story, Ruth. They can talk. So yeah. So fine for that point. We try to move our thing as fast as we can. That we prepare for that. That's why we just use the OR tent, not good buildings or bomb-proof shelter or something like that. We're gonna use that. We just use the OR tent, and we sample broke easily, and then move to a new place. And most of the time, I think that we will not. We think just a place for.
Yeah, we didn't stay in place very long because everybody knows what Google is. So
yep, it doesn't take long.
No, I mean, and sometimes it's it's not. It's well-intentioned information getting out. You have we took care of one little 4-year-old girl that had a evisceration, and Augustine was operating on her while her parents weren't here. They were in a different country. Her grandparents brought her in, and they want to talk because they want to notify the parents. And so that you got, then people are trying to get that message out either however they do, by phone or and so that pretty soon everybody knows where you're at.
How long do you hang out? How long do you normally stay?
This kind of depends, actually. I mean, again, that's just one of those feels that you have. I think, especially if you see something circling you, it's time to move, or if you get something near you, So
it's just more of like, we'll hang out here until we're pushed somewhere else.
Mm-hmm. We just start feeling nervous. Not very scientific of us, but
if it works, it works.
Yeah, well, so far it's been good.
Well, awesome. Hey, Mitch and Augustine, I really appreciate you guys jumping on.
Yeah, thanks, Dennis. Yeah, and I'd be glad to give you any thoughts that we have and or to help out. I think one thing doing this you realize is that there's really good people out there that don't have the resources or access to medical care, and it's a very, very rewarding to engage in their lives. Not saying we're bringing all the answers or everything, but you learn a lot from them too, just about some of life's most important questions, and as a human being. And I find inspiration from them. They call me Grandpa. That's so. I'm Becker. I'm very honored by that, but I'm also inspired by them and their dedication and their enthusiasm for their cause. And people say, "Why are you doing this?" And I say, "I get to do this. This is a passion. It's a wonderful thing to do." I don't know in the different setting if because there's all kinds of questions you could get into, political questions, moral questions. And I think you have to address those before you start, because that becomes your motivation to be there and to help. And if you don't know, if you're just going in for, again, have an experiential story to tell or a adrenaline rush, you're playing with fire. And and I think at the end of the day, it for me at least, it's about the people you're serving, and it has to be, you have to be able to trust them and work with them and plan with them, and and then I think you'll be inspired and you'll find strength from them too. So,
well, again, hey, thank you very much. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.